Hello, my name is Dr. Roger Henderson, and I'm a GP in the southwest of Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those of us working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, and really hope that you do, then do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. And in this episode, I'm going to be discussing peptic ulcer disease, and I'm also going to be talking about this in greater detail in one of our upcoming Study Group 6 meetings, which start this March, but don't worry if you missed that one, because these are going to be repeated throughout the year, every month, on a rolling basis, so we hope to catch you there. So let's look at what I mean by the term peptic ulcer, and I'm referring here to both gastric and duodenal ulcers. And I would define these as a break in the mucosal lining of the stomach or the duodenum greater than 5 millimeters in diameter, with a depth to the submucosa. Now, these are different to erosions, because these are ulcers smaller than this and without obvious depth. Now, peptic ulcers essentially result from an imbalance between the factors promoting mucosal damage, such as Helicobacter pylori and nonsteroidals, and those promoting gastroduodenal defense, such as mucus and prostaglandins. But H. pylori infection is pretty much key here, and I'm going to be talking about this in some detail, because it's associated with 90% of duodenal ulcers and 80% of gastric ulcers. Now, in the developed world, the incidence of H. pylori has been slowly declining over the last 40 or 50 years, but nonsteroidal use has been slowly increasing. The sex distribution is levelling out a little bit now, mainly due to Helicobacter eradication, and the incidence of peptic ulcer disease increases with age. Gastric ulcers would typically peak in the 5th to the 7th decades, and duodenal ulcers a little earlier than that. Now, as we all know, dyspepsia is a really common presenting symptom in practice, and about 1 in 3 of the population describe it every year, leading to a primary care consultation in about 5% of that group, and endoscopy in about 1% of that group. Now, I mention that because accurate estimates of peptic ulcer disease do require endoscopic studies, simply because the symptoms are so insensitive and such non-specific indicators of peptic ulcer disease. So in general, if we look at the etiology, duodenal ulcers are the result of hypersecretion of gastric acid related to H. pylori, whereas in patients with gastric ulcers, secretion is normal or low. And the 2 major factors I mention are infection by H. pylori and the use of nonsteroidals, and we now know there is some synergy between these 2 major causes. In duodenal ulcers, chronic H. pylori infection confined mainly to the gastric antrum leads to impaired secretion of somatostatin and increased gastrin release, causing gastric acid hypersecretion. Whereas in gastric ulcers, long-standing HP infection results in gastric mucin degradation and gastric epithelial cell death. We mustn't forget other possible factors here, including what I call the 3 S's: smoking, steroids, and stress, as well as increasing age and occasionally alcohol. Now, I'm going to go slightly off-piste for a second here and mention one of my heroes in medicine, which is Professor Barry Marshall, who won the Nobel Prize for his work in medicine, because in 1982 he put forward his slightly radical theory linking Helicobacter pylori to gastritis and ulceration, and that was ridiculed by his peers. Next year, he submitted his findings to the Gastroenterological Society of Australia, but the reviewers turned his paper down flat, rating it in the bottom 10% of those that they received that year. The next year, in 1984, he bit the bullet and drank a broth containing cultured H. pylori, and in his own words, he expected to develop an ulcer perhaps years later. However, 2 to 3 days after he drank that broth, he developed significant nausea and halitosis. From days 5 to 8, he developed marked achlorhydric vomiting and was really quite unwell, and he had an endoscopy on day 8, which confirmed massive gastritis. A repeat endoscopy at day 14 was unchanged, and he then commenced antibiotic treatment and improved. So we have him to thank for his rather brave self-experiment confirming the impact on H. pylori on our stomach. Now, taking the symptoms of peptic ulcer disease next, remember that a diagnosis can be highly unreliable on the history alone. But one of the common features is chronic or recurrent abdominal pain or discomfort centered in the upper abdomen. This is commonly related to eating, commonly worse at night, but may be relieved by food. Often relieved by antacids, but that's a bit non-specific, and there may also be nausea, bloating, and some distension. In some patients, there can be fatty food intolerance, but don't forget, if that's a presentation, also think of gallstones at that point as well. Looking at signs, there may be epigastric tenderness, and there may be the pointing sign, where the patient literally is pointing to the point where they feel the worst of the symptoms. So always check for that, but it's relatively uncommon. Unfortunately, there are multiple differential diagnoses of peptic ulcer disease, and just mentioning a few here, including irritable bowel, reflux, gallstones, Crohn's, pancreatitis, even stomach cancer and abdominal aneurysms. So we have to think about the wide picture as someone presents with what may be peptic ulcer disease. So how should we investigate that patient sitting in front of us when we're thinking, could this be peptic ulcer disease? Well, if you look at what NICE say, NICE has stated that endoscopy is not needed if it's a first-time presentation unless the patient is over 55 or there are warning signs. They say, irrespective of age, we should always be organising an endoscopy if there's iron deficiency anemia we can't explain, if there's weight loss, if there's progressive dysphagia, if there's chronic vomiting, if we find an epigastric mass, or if there's early satiety. If the patient is over 55, we should also be referring if there's a history of a previous gastric ulcer or gastric surgery, if they use nonsteroidals, if they have pernicious anemia, or if there's a family history of stomach cancer. Most of us would do bloods, and this may show an iron deficiency anemic picture, but this doesn't definitively diagnose peptic ulcer disease. Tests for H. pylori are really important, and I would suggest we use the urea breath test or the stool antigen test here. If these aren't available, then laboratory-based serology can be used, provided its performance has been locally validated. But don't forget that this is unable to distinguish between active and historical infection. Now, before testing any patient for H. pylori, always leave a 2-week washout period if they've been using PPIs, and a 4-week washout period after they've been using antibiotics, as both these drugs suppress bacteria and can lead to false negatives. Retest to confirm successful eradication of any H. pylori using a C13 urea breath test 6 to 8 weeks after starting treatment. So managing our patients with peptic ulcer disease, I suppose we've got 4 main goals of therapy. The first is to treat any active complications such as bleeding. The second is to eliminate the underlying cause whenever possible, and here we're most commonly thinking of H. pylori or the chronic use of nonsteroidals. We're also looking to relieve symptoms, and we're looking to heal any ulcers long term. Now, acute upper GI bleeding from a peptic ulcer requires urgent evaluation and admission. So we're looking at transfusion in line with local protocols, same-day endoscopy, and proton pump inhibitors to patients with a bleeding ulcer who've got signs of recent hemorrhage visible at endoscopy. But if we look at the three main groups of patients that would present in our practice, firstly, if you've got patients who are Helicobacter negative and peptic ulcer disease with no bleeding, then stop any nonsteroidals whenever possible and start full-dose ulcer healing treatment for 8 weeks. If you've got patients who are H. pylori positive, who don't have active bleeding and are not using nonsteroidals, then offer a 7-day course of Helicobacter eradication, and I'm going to come on to that shortly, in line with NICE recommendations, and consider offering ulcer healing treatment with a full-dose PPI or an H2 antagonist for about 8 weeks. And thirdly, if you've got your patient who's a long-term user of nonsteroidals, then stop those whenever possible and start an 8-week course of ulcer healing therapy with a full-dose PPI or H2 antagonist and offer HP eradication therapy. So let's look at HP eradication. This is really important because it leads to ulcer healing and it dramatically reduces ulcer recurrence. And most regimes of whatever type we like to use are up to 90% effective and are typically usually only limited either by antibiotic resistance or by patient compliance. So always stress the importance of adherence to our patients as we prescribe these. So if we look at eradication therapy, we're looking at triple therapy prescription, by which I mean a proton pump inhibitor plus 2 antibiotics first line. And I would recommend amoxicillin plus either clarithromycin or metronidazole, and then a twice-daily proton pump inhibitor of choice with a treatment course of 7 days. In patients who are penicillin allergic, then use a PPI plus clarithromycin plus metronidazole. And if you've got patients who are penicillin allergic and who have had previous clarithromycin exposure, then I would suggest quadruple therapy with a PPI plus metronidazole plus tetracycline plus bismuth. Now the good news that in practice most patients do not need to continue long-term acid suppressive therapy after they've had their HP infection treated. Looking at retesting or retreating, then if you've got an initially HP positive patient, retest them with a urea breath test 6 to 8 weeks after beginning eradication treatment. And as I say, always leave a 2-week washout period after a PPI and a 4-week washout period after antibiotic use before retesting so we don't have any false negatives. Retreat patients who are still HP positive with at least one second-line eradication therapy regime, and repeat endoscopy in patients with gastric ulceration and H. pylori 6 to 8 weeks after beginning treatment, depending on the size of the lesion. Now, personally, I would consider a specialist referral for any patient of mine with unexplained or treatment-resistant gastroesophageal symptoms, or if they have H. pylori that doesn't respond to second-line eradication therapy. What to tell our patients as they sit in front of us is pretty important, really. We should be advising them to avoid nonsteroidals, but if they're taking aspirin for secondary prevention of cardiovascular events, we should be advising them to continue that. If they're on other anticoagulants, then they should discuss the risks and benefits of continuing those with their specialist. If they do have documented H. pylori infection, we must remind them to complete the course of therapy even if their symptoms resolve, because these can resolve pretty fast. And also we should be advising them that if they smoke, they should do their utmost to quit, because smoking has been shown to not only increase the risk of peptic ulcers, but also affecting H2 receptor antagonists' action. I think we can also fairly safely advise them that it may be appropriate for them to return to self-treatment with antacids or alginates, either prescribed or purchased over the counter and taken as needed going forward in the long term. The outlook, fortunately, for peptic ulcer disease is good. With PPI therapy, duodenal ulcers typically heal within 4 weeks, and gastric ulcers within 8. So if you've got patients with peptic ulcers caused by H. pylori, the prognosis post-eradication is really good. The recurrence of a duodenal ulcer is reduced from 2/3 without treatment to 14% or so with eradication. The recurrence of a gastric ulcer is even better. It's reduced from around 50% without treatment to only 5% with eradication therapy. For ulcers associated with nonsteroidals, then discontinuing that nonsteroidal and eradicating any H. pylori present does lead to a low rate of ulcer recurrence. But if we have patients who have to continue using nonsteroidals, then ulcer recurrence is relatively high, so co-prescribing of a PPI is always advisable. So I do hope you found that run-through about peptic ulcer disease helpful, and thank you so much for listening. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. We really do love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening.